Hello, and welcome to the ANA Virtual Poster Presentation Session. I'm Peggy Bushey, and I represent the University of Vermont Medical Center. I am very excited to be sharing our poster information regarding the updated buttonhole cannulation method, and I hope that you take away a new perspective on the use of the buttonhole method. Buttonhole, or same-site cannulation method, has been employed on and off for decades. First introduced by Dr. Twardowski and utilized by AV fistulas only, it was felt to prolong the life of the fistula, cause less pain and trauma for the patient, and be a solution for patients with limited cannulation area. The buttonhole site itself is established by cannulating the same site of an AV fistula with a sharp needle for between 7 and 9 times, thus creating a track, much like that of a pierced ear. Once this track is established, you can now cannulate it with a blunted needle. The site heals between sessions with a small scab formation over the hole. Sounds great to me. If I were a patient getting stuck with large bore needles, then I would want a track formed and I'd want to use a blunt needle. But unfortunately, this method has also been associated with an increase in bloodstream infections, or BSIs. If we take a closer look at the etiology of these infections, they stem from the incomplete removal of the scab or skin tears at the cannulation site itself as a result of the scab removal process. Now, the traditional method of scab removal has been and continues to be the use of pickers supplied by the needle manufacturers, sharp needle points, picking out the scab, or tweezers. Now, this type of process can result in the scenarios I stated, which were incomplete scab removal and skin tears at the cannulation site. Scab particles are notoriously colonized with Staph aureus, and if left at the cannulation entrance site, they're pushed into the tract and then into the patient's bloodstream. Skin tears at the site from pulling off the scab, you pull off the skin, diminish the skin's protective mechanism and allows bacteria at the cannulation site to grow, which again is pushed through the tract and into the patient's bloodstream during the next cannulation. We had been using the buttonhole method in our home hemodialysis program. Our patients receive anywhere from 300 to 500 sticks per year from large bore needles. You know the needles I'm talking about. So we really wanted to continue to use the buttonhole method, which we felt was a better alternative, but we were concerned because we did see a slight increase in our bloodstream infection rate. We would comb the literature periodically, looking for any article that might give us insight into a better method, and we really didn't see anything until we happened upon an article authored by Mott and Moore that outlined a kinder, gentler method of scab removal that incorporated soaking and rubbing the scab off rather than picking the scab off. We went over their article with a fine-tooth comb. We tweaked their method slightly, and after a small test of change, we incorporated this updated method into our home hemo patient education program. Our poster outlines the steps, the complete steps that are taught to our patients. I just focused on a few here, so you can see really what we are emphasizing with our patients. One is the use of antibacterial pump soap to soak the scab with a sterile 2x2. The scab is then rubbed off with another dry 2x2. The big emphasis here is that we never use tweezers or pickers of any kind to remove the scab. We ingrain that into our patients. We reinforce it at any time we think it's necessary, but the real takeaway here is no tweezers or pickers, and we really feel that this was the game changer. We're able to remove the scab completely by rubbing it off. We don't cause any excoriations around the cannulation site by pulling off the scab. It's really been what we feel has made the difference in our program. So we're happy to state that since 2011, since incorporating that scab removal changed process, with an average patient census of between 15 and 20 home hemodialysis patients, we've had only one BSI. And that patient admittedly veered from the procedure using a bar of soap in his barn that had been in a sloppy soap dish. He cleaned his fistula with that before starting his session, and unfortunately that resulted in a BSI. So our mission here this year with our poster is to reignite interest and research into the buttonhole method with what we feel is best practice. Ditching the picking method for a simple soaking procedure is easy to do, it's sustainable, and has proven, at least to us, to yield positive outcomes. I want to thank you for listening, and I hope that I have given you reason to think again about exploring buttonhole method or taking a closer look at your current procedure for scab removal. Please feel free to contact us with any thoughts or questions, and enjoy the rest of the conference.